we consider all the therapies that are available for treating psoriatic arthritis patients, they've actually come in from very skin-related conditions. They got the indications first in psoriasis, and they then branched out into other manifestations of psoriatic arthritis, so moving on to articular manifestations, so trying to tackle skin and joint. What's happening now with the way the market is evolving, they've realized they need to treat the whole patient, and we've heard this quite a few times at Eular over the years. And what's come up in these lectures that we've been attending is a focus on pain. So outside of skin and outside of clearing plaque, outside of clearing skin and joint, there's now this focus on actually what more about it as pain. So that chronic elements of pain, the ability to tackle pain, and fast onset. So it's really branching out. What we've noticed in rheumatoid arthritis is tackling it from that point of view. They're actually very heavily focused on pain and then trying to branch out into psoriatic arthritis and then tackling skin thereafter. So who knows what's gonna come up in the next few years, broadening the scope really of what therapies are able to deliver to patients. The recent news about treating monotherapy has really come out from the JAKs that have been launched in the last 2 years now. And what I've found interesting from one of the lectures this year, it's challenging the way we use established therapies like etanercept. So in one of the talks they mentioned the THEME trial, and they had several treatment arms. Etanercept was being trialed monotherapy. Etanercept was being trialed in those patients that are methotrexate intolerant. And what's revolutionary for the RA space is that this will really widen the patient population that can now be treated, and possibly even treated earlier, because they potentially don't have to be treated for as long on methotrexate before even being eligible for biologic therapy. So amazing, really, what's going to come in the RA space in the next few years. So what we tried to do in the analysis for our poster was understand if physicians had any different perceptions with regards to originators versus the biosimilar brands. We took certain aspects of how physicians perceive specific associations of products, and we teased out whether they have different opinions of originators versus biosimilar equivalents. For this poster, we actually focused on specific ones. For example, here we analyzed etanercept, infliximab, and rituximab, 3 of the molecules that at that time in Q3 2018 had biosimilar brands available. For reduction in morning stiffness, you can see all across the molecules there's been a key difference here, significantly so, of how they think about the originators versus the biosimilar brands. Again, for a key efficacy point like helps maintain or improve physical function, inhibition of radiographic progression. And what's really interesting about this difference in perception is these brands have been available for a long time. Infliximab, for example, has been on the market now for well over 4 years. Etanercept biosimilars, some of them have been available for 3 years, the other one for 2 years. It's interesting that physicians actually innately think that they're different, and it would be very interesting to understand if that's how they actually prescribe. Do they prescribe differently when we know that they have this innate sense of there is a difference between biosimilars and the originators? So for this piece, for this poster, we analysed everything at EU5 aggregate, and some of the clinicians naturally wanted to understand if their region had any differences. So it would be great if we can see if specific countries are driving the differences that we're seeing. We know the UK is a very cost-constrained market. Perhaps that's a disparity there. We know that Germany is an early uptake of new mechanisms of action, so perhaps that's something else, another region that's driving some of the differences that we're seeing at this aggregate level. Another interesting question that came up is trying to understand if patients have similar viewpoints. There's several touch points where a patient can have an interaction with a clinician. So it could be when they're having a consultation with a rheumatologist. Does the rheumatologist even go in depth about the differences between the originator and the biosimilar brand? We don't know. It's something we really should seek to understand further. The patient then may have an opportunity to have a discussion with the pharmacist when the prescription's been filled. Again, we don't really know what that conversation is like. Do they then explain even further of potential differences between the originator and the brand? It's something we could investigate further for sure.